We're going to hear from Diana Lewis about the colonoscopy dashboard, where she describes the benefits of this project, not only to patients and to endoscopists, but to health services as well. So Diana, I'll pass it over to you.
Thanks, Wanda. At Northern, we've created a real-time colonoscopy quality dashboard that has all the quality indicators in it. So colorectal cancer is the fourth most common cancer, and polyps are precancerous lesions in the bowel. And colonoscopy can detect those cancers, and by those polyps, and by removing them, about 70 or 80% of colorectal cancers can be prevented. And interval colorectal cancer is cancer that occurs before the next date of the next colonoscopy, when they've already had a clear colonoscopy. So I'll just flick through a few things there. Colorectal cancer is expensive, and late-stage colorectal cancer costs a lot more. So the quality of colonoscopy varies significantly, and it can be very operator dependent. And there are some key quality indicators for colonoscopy, including bowel preparation quality, cecal intubation rates, which is the percentage of colonoscopies where the cecum is fully intubated, and then adenoma and serrated polyp detection rates. The adenoma and serrated polyp detection rates is a percentage of colonoscopies where an adenoma is detected and a percentage of colonoscopies where a serrated polyp is detected. And if all of these are improved, then the rates of interval colorectal cancer are decreased. Now, because the quality of colonoscopy varies significantly, auditing is mandated by the Safer Care Victoria and the Australian Colonoscopy Clinical Care Standards. So at Northern Health, we used to have an endoscopy nurse who would audit every single one of our colonoscopies and calculate our adenoma and serrated polyp detection rate by manually checking each report and histology report. And it took them 6 weeks a year full time to do this auditing properly. In other places, they use junior doctors to do it. Some places they don't perform audits regularly, and in other places, very low numbers are audited. If auditing is done properly, it would cost over $1 million over 5 years with staff time, but that doesn't take into account the negatives if auditing isn't done. So poor auditing can significantly compromise patient care, so you risk not detecting poor performance or detecting it late. And there were over 2,000 colonoscopies recalled for a single endoscopist in rural Victoria a few years ago. 1,000 of these patients had repeat colonoscopies, and 7 of those had bowel cancer, which is extremely high, a very high rate of interval colorectal cancer. The other aspect is the loss of trust in healthcare. So I see a lot of patients in my private rooms from rural Victoria, and especially in that area where there were a number of patients recalled for repeat colonoscopies, patients don't want to receive their care locally and do come down to Melbourne for endoscopy, which I think it's just that loss of trust in healthcare is major. So the solution is using automation. So Northern Health have developed a real-time dashboard that includes all of the quality indicators with the adenoma and serrated polyp detection rates, cecal intubation rates and bowel preparation quality for the health service and each individual endoscopist over time, along with waitlist data and outcomes data as well. So this is the colonoscopy. If you could just press play on the thing. And so this is the opening dashboard. It has the number of patients who were referred for a colonoscopy, those who had the procedure within a timely fashion based on their category, as well as the overall just data about the procedural outcomes, such as the bowel preparation quality and cecal and adenoma and serrated polyp detection rates, as well as some complication data too. So looking at those who have had their colonoscopy within the appropriate time frame, we can see based on different health services what percentage are having it, as well as for each subcategory, how many are having it within the recommended time frame. And we've got similar data as well for those having more emergency procedures, as inpatients more so. For our bowel preparation quality, the clinical care standards would say 95% is what we should aim for, but as a health service with our very complex patients, we accept 90% as our cutoff. And the bottom graph has a whole heap of columns, which is each individual endoscopist and the number of colonoscopies that they've performed in the time frame, all de-identified. And then the line is the bowel preparation, the percentage of patients with adequate bowel prep that they've reported. Similarly, the cecal intubation rate, the bottom graph has each individual endoscopist with the line at the being the percentage of colonoscopies where the cecum was intubated. The dashboard's interactive, and you can see that if you select just patients with inadequate prep, the rates of cecal intubation go down significantly. For our adenoma detection rates, again, similar graph with the columns at the bottom and the line being each individual endoscopist. The bare minimum for adenoma detection rate is 25%, which most people are meeting. And we can look at the data in a lot more detail with the actual raw percentages for each de-identified endoscopist. If you select one endoscopist, they can look at their data in more detail, looking at it over time, and looking at over shorter time frames as well. And you can see this endoscopist in the last financial year had only 80% of patients had adequate prep, and adequate preparation is actually after time has been spent washing and cleaning the bowel. So obviously they've seen that data, they've improved their rates of washing and cleaning the bowel, and have improved this financial year their bowel preparation quality rates. And along with that, their adenoma and serrated polyp detection rates have both gone up as well. So the benefits are that it's time saving, you don't have to do any manual auditing, the data is live, and the auditing is far more likely to occur. I think if we're actually auditing, we can actually make sure that the provision of healthcare and quality of endoscopy that we're providing, no matter where people access the endoscopy, will be the same. Because it's real time, we can monitor new endoscopists and any endoscopists who require improvement if we change any procedures such as bowel preparation instructions, and we can detect and address any issues in quality early and reassess it as well. So ultimately, I'd propose that it'd be fantastic to roll this out to some other health services as a pilot study, and then hopefully roll it out sort of Melbourne and statewide, and then even Australia-wide ultimately. And it would allow for benchmarking of quality between health services as well. To be able to roll this out to other health services, we'd need some sponsorship and partnership as well as support to roll this out. And we would need some extra staffing hours, I suppose, to actually be able to do this. And the health services would need electronic endoscopy and histology reporting to be able to have this dashboard up and running. We are doing some other work looking at creating a REDCap database to sort of use in some ways for endoscopy reporting, which is underway at the moment, creating a data dictionary. And places around the world are also quite interested. So the gastroenterologists in Mongolia are looking to set up something similar that I'm working with them for that as well. And there's also opportunity for other dashboards, such as assessing the indication for endoscopy, gastroscopy quality indicators, and advanced endoscopic quality indicators are some examples. So I'd just like to acknowledge these people. Leanne is on our digital team and has done a huge amount of work creating the dashboard as well. And Melissa, Will and Ben all sort of went through thousands of patients' data to double check the accuracy of it as we were creating this dashboard. So thank you.
Thank you so much, Diana. And well done, Northern Health, and all whilst we saw early on during Cameron's session how the activity at Northern is just booming through the roof. So I imagine that makes it all the more necessary, but also challenging sometimes to take time out and do these projects. But well done on bringing together your clinical skills and your operational, strategic and technological thinking. It's amazing, and yeah, it's very inspiring to see work like that. Are there any questions?
Thanks, Diana. Excellent presentation. I just have one question. In terms of how does it account for complexity of the case? Do you also collect data about their comorbidities to determine, what's the complexity from one hospital as compared to other? For example, tertiary centers may see more complex and complicated patient as compared to the other hospitals.
So we are reliant on the data that's collected as part of the Victorian admitted data set. And that does include some of the Charleston Comorbidity Index, but that's also reliant on data that's entered within admissions and things like that. So there is some aspects of endoscopy that we can see the complexity of patients, but we haven't included that in the dashboard because it is data that's so reliant on so many different things that it's not the best quality data and not that accurate.
Thank you. Linda Nolte?
Yeah, thanks so much for a great presentation. Hopefully you can hear me okay, can you? Yep, great. I just had a question because you started off about the importance of doing this auditing and for safety, and I was wondering what is better Safer Care Victoria saying about this particular platform, because this is excellent, and I'm quite interested to understand what their buy-in to this piece of work is. Thanks.
So we did present it to Safer Care Victoria, who were quite interested, but it's sort of just nothing much has happened.
There's certainly an interest. I think we do have to do a proof of project with potentially a pilot. We've got a couple of metro services and rural interested to see how we could roll that out in a smaller pilot and then where it might land. But it certainly has improved the clinicians' sort of recognition of the work they need to do in their own upskilling. There was first resistance around it, but I think now they're very much more open and have seen the benefits of being able to talk to each other about, why they have different rates, what they could each do to improve things. Equally, from the nurse's point of view, it's really released them from a very boring, mundane task and with the registrars to allow them to go back into that clinical area. So it's benefited patients to have the nurses back in the clinical platform rather than collecting data. And it is real time. We don't have to wait 12 months and then we're 12 months behind in the results. So there are lots of benefits, and I think there are benefits to look at, are the current requirements the absolutely best quality requirements. It allows us to review all of that, and there have been already some changes in what is required to be collected through the Gastroenterological Society.
Yeah, thank you.
Thank you very much. I would perhaps hazard a guess too that the last 6 months plus has been an even busier than ever time at the department and SCV. So, I know, Wanda, you've got plans to sort of continue those conversations with Diana as well. So, yeah, we look forward to seeing this pilot turn into a scale up because it's too good a piece of work to not be scaled up. So well done, Diana and all the team at Northern Health. That's a great example of an initiative.